So that's the question in major acute presentation 6. I'll ask you to pause the video and write down the answer. Let's move ahead to look at the answers. What happens to the oxygen dissociation curve at high altitude, and what do you expect to see on the blood gas? So when you're climbing high on the mountain, what happens is you are gonna breathe faster, so you will be hyperventilating initially until you get acclimatized completely. So hyperventilation leading to respiratory alkalosis, absolutely right. And whenever respiratory alkalosis happens, there is an increase in 2,3-DPG, and increased 2,3-DPG moves the curve to the right initially until it settles down to the left. But the right answer would be right shift of curve. Assume a diagnosis of high altitude pulmonary edema. Apart from oxygen, name 2 drugs that can be given. There is at high altitude, you give them sildenafil, and you can give them a calcium channel blocker, nifedipine, and dexamethasone. So it says, how can you prevent the development of high altitude pulmonary edema? You can do it by doing a gradual ascent. You can do slow ascent and have rest days for acclimatization. So how they do it is they climb high and then come back few meters or few feet and sleep low. So climb high, sleep low is the term which they use. So they come back and camp down a bit lower than where they went ahead. And there should be rest days for acclimatization, avoiding alcohol or sedatives, and avoiding exertion at high altitudes. So these are the few points. You can write 2 of them. Let's move on to the next one. You can pause the video here. Give yourself 2 minutes. Okay, so this is a young guy who's come in with severe signs of hypovolemia or hypotension, and they said that this is acutely happening, and chest x-ray is done, so there is no trauma or anything, and you need to find out the abnormalities in the chest x-ray. I'm sorry, over there was a typo, so it's the abnormality in the chest x-ray. So let's do the same thing. A, airway, trachea is midline, so it's not abnormal. B, breathing, the lung markings do not extend up to the periphery, so that is one abnormality. The lung appears to be collapsed, and there is hyperlucent shadows seen between the lung and the thoracic cage. And although the BTS algorithm clearly states that you need to have you need to classify it as primary and secondary and see the distance, whether it is 2 centimeters or 1 centimeter, and accordingly act. This patient is unstable. So if you look at the BTS algorithm, which clearly states that if the patient is unstable or has bilateral spontaneous pneumothorax, the first thing you do is you move the patient to resus, and you're gonna get the IV access, oxygenation, and you're gonna put a chest tube, not a needle thoracostomy, a chest tube. So a chest tube should be done, intercostal tube, and secondly, fluid can be given to take care of the hypotension as well. He's ready for discharge in the ward after 40. What advice? So some people said no flying. It's like the patient cannot fly until he sees the chest physician and he is given a green signal. He can never do deep sea diving, and some people have written advised not to smoke, but he does not smoke, so that will not give you any marks. You cannot advise a non-smoker don't smoke. So this would be it. So if you look at the answers here, I'll mention the answers. Move the patient to recess attached monitor, prepare for intercostal drainage on the right side. Diving is not allowed, no air travel for 4 to 6 weeks. Repeat chest x-ray and respiratory clinic follow-up. And that's the BTS algorithm. Spontaneous pneumothorax, if bilateral or hemodynamically unstable, proceed to chest drain. And then comes the classification. So that's an important thing which you need to remember. The next one, you can pause the video again over here. Okay, so what is the pathophysiology of the diagnosis in consideration? You very well know that this is gout. So deposition of uric acid crystals in the joints is the pathophysiology. It can be, you can also mention hyperuricemia due to either increased production of uric acid or reduced excretion. What investigation can be done acutely? Chest x-ray is not recommended, neither is uric acid levels. So what we can do is we can do a aspiration of the joint and ask to see the crystals, and you will see negatively bifringent. Write negatively in words, not with a minus sign followed by VE. Okay. Name 2 drugs that predispose to this condition. It's thiazide diuretics, not furosemide, and low-dose aspirin. Alcohol can be one. So this is a case of a lady who's been vomiting a lot, and because of that she had some blood. So what is the most likely cause of her hematemesis? That's Mallory-Weiss tear. What 2 scoring system? It's Glasgow-Blatchford scoring or Rockall scoring. Name 2 drugs that have mortality benefits. Many people have written octreotide. Octreotide has not been proven yet to have mortality benefits. Terlipressin and antibiotics, which is ciprofloxacin or ceftriaxone. Tranexamic acid has no mortality benefits. Next one, you can pause the video. What is your diagnosis? What procedure can be deployed in the ED to correct the diagnosis? It is benign positional paroxysmal positional vertigo. And what procedure? You do a Epley's maneuver, not Dix-Hallpike maneuver. Dix-Hallpike is a diagnostic test, not a corrective measure. So Epley's maneuver. Apart from Meniere's disease, give 2 differentials. You cannot write down BPPV over here again. You need to write down something else. So labyrinthitis, vestibular neuritis, those things will be the answer. What is head impulse test? Head impulse test is used to diagnose vestibular neuritis. Or how is it performed? You need to fix the patient's head, ask him to look at your nose, and you need to rapidly turn the head around, and the moment he loses focus, you can say that if he loses fixation of his eyes transiently, the test is positive. I would rather not use vestibular neuritis in question 2, because again I'm using it for number 3, so they might not give marks. So labyrinthitis and acoustic neuroma will be the answer. This one will remove and this one will remove. Let's move on to the next one. Again, pause the video, take 2 minutes and write down the answer. What is the most likely diagnosis? Give 2 reasons that may have precipitated. So the most likely diagnosis over here, based on the scenario given, is a thyroid storm. Yeah, so this is thyroid storm, and 2 reasons could be septicemia or electrolyte abnormalities. However, electrolyte looks normal, so I would say septicemia and acidosis would be the thing. Or she might have overdosed herself with some medications. Describe the abnormalities. Again, you go with the rate rhythm axis. So rate is tachycardia, rhythm is irregularly regular, and axis is normal, so it's okay. And you do the P waves, absence P wave, so that gives you 2 points. You have initiated fluids and 2 medications you need to give. So thyroid storm, what would you give 2 medications apart from antibiotics and antipyretics? You will have to give propranolol followed by propyl thiouracil and hydrocortisone. You cannot give iodine before you give propyl thiouracil. So people who have written iodine as first answer may not get it right. So the next one, you can pause the video here again. Okay, so the blood gas shows this, the ECG is above, what 2 treatment would you initiate? So based on my diagnosis of norepinephrine overdose, which is a TCA overdose, I will give her a liter of fluid, IV 0.9% normal saline bolus, and I will give her 50 millimoles of sodium bicarbonate, not soda bicarb, sodium bicarbonate IV. Then what are the indications of using the above drug? We'll see the indications, and if her observation remain as above despite using the above drugs, what 2 other medications can be used? Remember, TCA has alpha blocking effect, has sodium blocking effect, and has anticholinergic effect. So you cannot use a sodium channel blocker like phenytoin, or you cannot use any antiarrhythmic or amiodarone, or you cannot use any lignocaine or anything like that. What you're going to use is you have given fluids, not reversing to not responding to fluids and sodium bicarbonate. What would you do is there are 2 drugs which are of the last resort. One is intralipid emulsion and second is glucagon. Third one is high dose insulin. However, you don't have to go up to that level, so you can write intralipid emulsions and glucagon. Magnesium sulfate is not there. So hypotension, not responding to fluids, arrhythmia, and QRS more than 120 milliseconds is the indication for using sodium bicarbonate. Let's move on to the next one. So 28-year-old lady in the ED with painful rash on the legs bilaterally for last 4 days. Okay, pause the video and write down the answer. Give 2 drugs that are responsible for this rash. Young lady, what she will be taking: oral contraceptive pills. Sulfonamides is another one. Give to infective causes. Think of all the granulomatous diseases: tuberculosis, syphilis, not herpes simplex or Epstein-Barr virus. It's TB, syphilis, leprosy, and everything which can give rise to granuloma. So histoplasmosis, coccidiomycosis, here the systemic fungus can give rise to it. And in non-infective causes, again, granulomatous lesion could be ulcerative colitis or Crohn's disease. You can put pregnancy in this. What scoring system? It is called as score 10. So the next one is here. Pause the video again. Okay, so what 2 bedside investigations are mandatory? So what will be bedside? She is a female, she has never been pregnant and has no medical, she is not allergic, so they have not done a urine pregnancy test, so we can say that. And we can ask for right flank pain, dizziness, and bleeding for vagina. You can do a venous blood gas to look for hemoglobin, because if she's bleeding we need to know if she's okay. So has she bled that much that her blood pressure is 88/62? So urine pregnancy test, urine dipstick. Venous blood gas for hemoglobin is the answer. What aspect of history is essential? History of sexually transmitted disease and other things. In the recent FRCEM final exam, they asked give 6 historical features in sexual history. So remember, you should be able to remember 6 questions of sexual history. What is the definitive treatment for her diagnosis? So this is ectopic pregnancy, unstable, will need to go for surgery. So you do a laparotomy or laparoscopy plus salpingectomy or not MTP. One of the student has written MTP, which is not the right answer. And MTP, first of all, is an abbreviation and nobody knows about it. In the history, blood group type is very important as well in all pregnant ladies. You can ask about ovarian cyst and tumors, congenital anatomical variations. Let's move on. Okay, let's pause the video again. Okay, describe the image seen on fundoscopy. See what you write. Write what you see. So you see a pale optic disc and you see a cherry red spot. So that's the 2 points. Topical treatments, massage the globe and topical timolol. Give 2 causes of painful visual loss. Acute angle closure glaucoma, not AACG, right? Acute angle closure glaucoma, temporal arteritis, optic neuritis, migraine. Again, 2 minutes. Okay, what bedside investigation is mandatory? Give 2 differentials for a stroke mimic. I would do a finger stick glucose, and 2 differentials would be hypoglycemia, postictal state. What are negative predictions of predictive symptoms in Rorschach scale? So altered level of consciousness and seizures. What 2 blood parameters are contraindications to thrombolysis? So they have clearly mentioned blood parameters, platelet count less than 100,000 and an INR greater than 1.5 or 1.4. Okay, pause for a minute, pause for 2 minutes and write down your answers. Okay, so you inform the nurse in charge and enter the room while police are waiting outside. He's angrily making eye contact and you assume he'll become violent and will need rapid tranquilization. What measures are proposed? So NICE says first you need to go ahead with de-escalation techniques. De-escalation is not making eye contact, not showing your back to the patient, keeping a neutral posture. So you can write de-escalation technique, and then comes physical restraint, then medical restraint. And medical restraint starts with oral medications, then IM medications, and then IV medications. So what is the drug of choice? If the patient does not have any past illness of psychiatric issue, then benzodiazepines, that's lorazepam, 2 to 4 milligrams per oral, followed if you can't give oral, 2 to 4 milligrams IM. If you can't give IM, you give 2 to 4 milligrams IM. If the patient has psychiatric issues, you add haloperidol. What should be available immediately when you're tranquilizing? So first thing is you may over-sedate the patient. So you need to have flumazenil available. That's the antidote for benzos. Remember, flumazenil is not used routinely because it can potentiate seizure in chronic benzo patients. And so flumazenil, resus equipment should be available. So these things, resus equipments and drugs such as flumazenil. Procyclidine is, if you use haloperidol, they might go into extrapyramidal symptoms, so you have to keep some procyclidine as well. Pause for a minute. Okay, what is defined as a significant exposure for chickenpox in pregnancy? What would you do for her now? And what are the fatal complications? So this lady doesn't have any history of chickenpox in the past. Significant exposure is called as 15 minutes in the same room. And what would you do? Because she has not been exposed, I would rather just do a varicella zoster titer and varicella zoster immunoglobulin. Administer the globulin because there is no history. So just give the immunoglobulin. And what are fatal complications? You can classify it as maternal and fetal. In the early pregnancy it is fetal, and in the late pregnancy it is maternal. In the early pregnancy it is fetal, so fetal varicella syndrome. In the late pregnancy it is maternal, so maternal pneumonitis, encephalitis and hepatitis. So additional acute presentation, pause the video over here. Okay, so this is a question which shows all the adrenergic features over here in this patient who had been recently discharged following a fracture at C7 and T1. So whenever you see adrenergic changes in a patient with a recent spinal fracture or an old spinal fracture for that matter, you need to think of autonomic dystrophy. And autonomic dystrophy, so it can be due to a catheter which is blocked, or a catheter or a urinary retention, or rectal, I mean to say constipation itself. What part of physical examination is mandatory? Yeah, the question was not clear whether we have done a complete neurological assessment. So you might gain some marks if you write down neurological assessment, but what the question was looking for was a rectal examination, because he had constipation history. He has not passed stools for 3 days. What is your clinical diagnosis? Autonomic dystrophy. And how would you treat the condition? You will manually evacuate the rectum or give enema. And you can treat the blood pressure with nitrates and nifedipine. These are short and quick acting. Next, pause the video. Okay, describe the abnormality in the picture. So it is, what do you see? You see a break in continuity in the lateral tibial condyle, suggestive of right tibial lateral fracture, lateral. And Ottawa knee rule, age greater than or equal to 55, isolated tenderness of patella, tenderness at fibular head, unable to flex knee to 90, unable to weight bear immediately, and in the ED, limping is okay. This rule cannot be applied to less than 6 years of age, pregnant ladies, and anybody above 55. McMurray's test is a rotation test to demonstrate the injury to the meniscal cartilage. They didn't ask you how to do it, they just said what is McMurray's test. Okay, pause the video over here. Okay, so this guy is coming with burns on the face and his blood pressure is low. His mustache and beard and lips are burned. That means airway is compromised. He is breathing heavily. That could be due to the pain itself. So saturations are 92. You have got an IV access. Routine labs are carried out. What treatment should be offered? I will definitely start with some fluids. So I will give IV 0.9% normal saline, 20 ml per kg body weight, or as per Parkland formula. IV morphine 5 to 10 milligrams, 2.5 to 5 milligrams. IV paracetamol 1 gram. What could be the pathophysiological cause of his hypertension? We'll look into it. He's intubated. Now you can't see good chest rise, so what you'll do, escharotomy. It's not fasciotomy, it's escharotomy. Okay, let's move on. Pause the video here. Okay, so give 2 donor high-risk factors for blood-borne viral transmission, and you decide to do blood tests. What you need to do before that, and what test would you request, and what are the risk of transmitting HIV. So let me tell you, the donor high-risk factors are: if the patient is known HIV, known hepatitis B or known HCV, terminal HIV-related illness, homosexual male, acute liver disease, IV drug user, or recipient of blood or organ transplantation. Immunocompromised state is not given in the question, in the answer, and patient from African origin is not an answer. He should be known HIV, hepatitis B or HCV, or terminal HIV illness, IV drug abuse, or homosexual male. Consent to be taken from source or donor for HIV, hepatitis B and C testing. Do a serum hepatitis B titer for this patient, this recipient, and a serum save for future baseline hepatitis C and HIV testing. If you see, he's taken 3 vaccinations, so he's fully immunized in past 5 years. So what is the risk of transmission of HIV through contact with saliva? None. If it's not bloodstain, none. And there's reasoning for that. The reason is human saliva contains neuroaminidase inhibitor, so which is basically which does not allow the HIV virus to flourish. If the donor is hepatitis B positive, what treatment is recommended? Yeah, if the donor was not hepatitis B positive, then no treatment required, or it's within the past 5 years, so we can wait for the titer and give the booster. But if the donor is hep B positive, you immediately give 1 booster dose of hepatitis B. Next, pause the video for a few minutes. Okay, we have done an examination of his genitalia. What are the clinical signs of testicular torsion? So, tenderness on the testicles, horizontal lie of the testicle, elevated testicle, absent cremasteric reflex, French sign, angel sign. What do you understand by clapper belt deformity? Clapper belt deformity is like usually the tunica vaginalis is attached on the posterior aspect. If there is high attachment of tunica vaginalis, then you call it clapper belt deformity. What infective organism may give rise to testicular swelling? It is mumps, or there is a bacteria which is found in camel, Bordetella, I think. Yeah, we'll look at it. Apart from infective causes, give differentials. Brucella. So brucellosis can cause, that's the organism, and non-infective causes could be trauma, incarcerated hernia, and torsion of hydatid of Morgagni. Let's stop here, and I'll see you in the next video.